All right, so a little common sense here. If you do have a suspected skull fracture, you don't want to push on it, right? There's a difference between palpation and pressure. So don't push, right? Just palpate. Oop, if you're a little crepitus, you're not going to sit and poke at it. So that's common sense. If it is an open fracture and you see contents or suspected brain contents, do what you always do. Moist, right? A moist bandage, moist sterile bandage, and wrap it up and get them moving. All right, so traumatic brain injuries. We get primary injuries and secondary injuries. The primary injuries is injury from the collision, right? This is the bruising, the contact, the hitting, whatever, right? And then there's a secondary. Secondary is something that can make it worse, and that would be swelling, right? Edema, right? Hypoxia, low oxygen, low blood pressure, not getting enough blood up there, right? Bleeding, right? Ischemia, which is lack of blood flow, or infection, yada yada. Those are things that are going to aggravate that initial injury, make it worse, if not cause their own separate injuries, right? So brain injuries can be blunt trauma, right? You can hit your head. You can penetrating trauma. It could be gunshot, stab, arrow, whatever. So they can happen from a variety of reasons, which we know. And then the book makes reference to this counter-coup injury, which is essentially the opposite side of the brain. If you get hit in the front, your brain sloshes, right, and then sloshes back, and there could be trauma on the back side of your brain. It could be side, it could be, lateral collisions, whatever. It's not necessarily always, it's not always front and back. It can be any, but it's an injury to the opposite side of the brain from essentially that slosh and slosh back movement. Okay. Edema, swelling may not happen until later. Okay. It may be later that the swelling starts. So, not all that long ago, Das Colcato, who we compete against, had a football player who had hit his head, concussion. They did everything right, to my knowledge. And then we got back to school, getting off the bus, and he collapsed. The swelling, it was an hour or 2 hours later, that pressure swelling built up in his brain. He collapsed. I believe he survived and did fine, but he was in rough shape for a while. But it was later on that swelling. That's why we monitor concussions, right? That's why when we take them to the hospital, and they're monitored there, or the hospital has people monitor them at home, just because it might kick in later on. So your brain is only your skull is only so big, right? So if we start packing fluids or blood in there, right, we build up pressure, and that pressure is not good for your brain. If you think about it, it's probably not real good when your brain gets squeezed or squeezed against the skull, right? It can cause issues, cut off blood flow. That extra pressure is not good for certain parts of the brain. So kind of depends where this pressure is at, right? If I've got swelling on the right side of my head, it pushes the brain to the left, and whatever's controlled over there is going to be affected. Excuse me, fire call. Scratch that, got canceled, so I'm good to go. There it comes. Hold on. There it comes on the cancel page. Comes across the phone a lot. All right. So depending on where the swelling has happened, we can get this wide variety of symptoms, right? All of these would be considered possible neurological related symptoms, even though they don't present as neuro symptoms. Bradycardia, right? Depressed heart rate. A lot of these things can appear to be just normal, but after a head injury, not normal symptoms, but symptoms of something else. But after a head injury, they take on a different meaning. So just be looking for that. All right, hold on here. Click here. Intracranial hemorrhage, bleeding, right? We know hemorrhage means, bleeding, generally large bleeding. Can also increase ICP, right? That as that blood, instead of staying where it belongs, right? It's going to seep into other areas, and it's going to increase that intracranial pressure. It can occur between the skull and duramater, and this is fairly significant. We'll talk a little bit about that down the road here. It can occur between the skull and the duramater, underneath the duramater, but outside of the brain tissue itself. or within the brain. Okay, so the epidural hematoma, that is outside of the duramater, essentially outside of the brain. Okay, biggest concern here is that pushing, right? If you've got the hematoma going on here, not only are you impinging on this tissue, right, but over here too. Okay, so that the blood is outside of the brain, generally from some type of a blow, right? Punch to the head, bat or whatever, assault. And a lot of times, most of the time, this is going to be attached to a skull fracture type situation where that injury there's an imminent injury outside. Okay, subdural hematoma is under the dura, but there's not bleeding outside. Right, so this is a lot of times strong deceleration forces. Right, there's no fracture necessarily to the actual skull, but it's the brain sloshing around. There's a lot of contact there on the inside. Okay, but it's outside the actual brain matter, but inside the dura. And then there's intracerebral hematoma, which is inside the brain itself. Not a ton of blood flow in there, so not horribly common, but it can happen. Okay, generally following a penetrating injury where it's made a hole, right? Or again because of rapid deceleration, high MOI scenarios. Subarachnoid hemorrhage occurs in the cerebrospinal fluid, essentially. In that you might get, this is where the halo test is going to come in. You might get what appears to be blood or bloody, light colored blood, bloody CSF. This could be an aneurysm rupturing. It could also be trauma. A variety of things here that could cause that bloody CSF. Concussions. Anybody who's in sports in high school knows a lot about concussions, right? We talk about them a lot.
Mr. Kelly 2601.
They're considered to be relatively mild compared to where there's actual contusions going on, right? Hopefully temporary, usually fairly temporary symptoms with this, and most don't experience a loss of consciousness. They don't lose consciousness with a concussion most of the time. They might be confused. They might have some vision problems, right? They may have a headache. Usually it's a relatively short time, relatively quick recovery from a concussion. Sometimes not, but usually it tends to be the least severe. Okay. Contusion, right? There's actual damage. There's actual bleeding, usually bleeding damage to the brain, or subdural, epidural, somewhere in there. There's actual collection of blood, right? And it can be permanent, if it's not treated well, or it could be permanent anyway. And this is a classic brain injury, right? Contusion, more severe than a concussion. Other brain injuries, we could have clots and hemorrhages, right? Strokes. That's what we're talking about there. And it can be we could be slurring words. You could have headache. They could be confused, right? Could have vision issues. Same variety of issues that you see with other TBIs, even though it's not technically traumatic. All right, spinal injuries. Okay. There's a variety of forces that can occur on the spine, right? It can be compression. You can hit your head. Think football players making contact head first. You can compress the spine, which can herniate discs, and if you're lucky, that's all it does, right? It's going to compress the discs, right? It can be overextended, hyperextended, right? It can be rotating injuries, torque injuries on it. So there can be a variety of things that happen to the spine, okay? Now, the spine is protected inside the vertebrae, right? But fractures to the vertebrae, right, can cause fractures of the vertebrae, or high forces on the vertebrae can cause damage to those spinal neurons, right? So the issue comes in when there's too much force exerted and they break, right? Broken bones along tissue are never a good thing, right? Or just there's so much torque on there that they impinge on that spinal cord. that's where you get actual spine injuries or spinal cord injuries. All right, so anytime we have a motor vehicle, MOI, right? High MOI, high energy MOI. Okay, if we hit by a car, if they fall a great distance, okay, or even a short distance and hit their head, they don't have to fall very far. Right? Remember, you hit your head on the corner of the dresser, that can be a real bad day. Okay, blunt trauma, right? Hit with a bat, right? Hit with something, or something falls on their head, or any penetrating trauma to the spinal area or the head can result in brain spinal injuries. Okay, rapid deceleration. Okay, that's any collision fall. Hangings, anytime, whether suicide or not, anytime somebody is hung by the neck. Axial loading injuries, that's like football, that's where you're hit hard on the head down the spine, which often includes diving accidents. Not that long ago we had a couple of diving accidents in the same summer. Somebody they dive in to shallow water head first, full body weight on their head, can cause spinal issues. So scene size up, just like always. Take a look around, make sure that it's safe for you. Look for indicators of MI. How high was the ladder, right? How bad is the car beat up? Okay, what type of collision was it, etc. Life threats always first. We know that, right? And get them going. So if we've got a brain spinal damage, there is nothing you can do to save that. Well, not to save, to make that patient better, right? When they've got a head injury, the best thing you can do is get them to a higher level of care or definitive care, right? Spinal immobilizations, immobilize them, right? Assess them how they're found. Let's roll this guy over right away. If they're face down, talk to them. Start your assessment face down, right? So, and even a backboard. Backboards are great for carrying. They're starting to. We're not using them for splinting as much anymore because your spine's not straight, right? So a backboard is not a correct spinal alignment. It's used for carrying, right? But we don't want to leave them sitting on it for long periods of time. So they're on their face. As long as they can breathe, you can start your assessment while they're on their face. If they can't breathe, then we got to talk about it, right? We got to figure something out. Cervical collar, put it on when you need it. Leave it on. Okay. If you have to take it off for any reason, you want somebody holding C-spine. Even with the collar on, you want somebody holding C-spine. But there's no question that if you ever have to take that thing off because they can't breathe, get it on or get hands on, right? What's bothering them? What's their biggest complaint, right? We always ask them chief complaint. Chief complaint isn't always the biggest thing that you see wrong with them. It's what they feel, right? So they may be confused. They may slur, right? They may ask you what happened over and over again. Not uncommon with head injury. So we had a football player here, and actually wasn't a real big contact, who kept asking, who hit me? And it was in practice, and we'd tell him, and, he'd come back 2 minutes later, hey, who hit me? So they're a lot of times they're going to ask the same question or same type of question over and over again. Okay, and at the bottom, always assume head injury until a doctor says no. Right, unresponsive trauma. If you're in a bad car wreck, patient's unresponsive, they can't respond to commands. Assume it's a spinal injury. The end. Treat it like a spinal injury, and get going. Okay, you're not going to sit and putter around with that. Okay, decreased level of responsiveness. Right, if they're not responding correctly, we're thinking brain injury, spinal injury. Okay, airway, breathing, circulation. Right, might have to use jaw thrust. If they have a head injury, or neck injury, we're not going to crank on the neck. We're using the jaw thrust. Right, have suction ready, because that's oftentimes a side effect of brain head injuries. Irregular breathing. Right, that's if you've got pressure on that particular portion of your brain, you might have irregular breathing going on. Okay, and if they're head or neck, give them oxygen as much as you can. Okay, slow pulse or slow breathing, right? Irregular breathing is indication that something's really wrong. We know that. Looking for shock, controlled breathing, you have to have it. Right, manner of transport. We may have to get this person out and get them going quickly, right? Try to maintain as best you can stability, get them out and get going